Now, the coronavirus pandemic is still ravaging lives and property. So far, over 3.1 million cases of the virus has been confirmed globally, with the total death toll standing at 217,183. That's according to a tally by Johns Hopkins University.
Very well, sir. The United States leads the number of cases per country with just over 1 million people infected with the virus. Western Europe follows suit with Spain, Italy, France, and the United Kingdom now has the 5th worst death toll in the world, with Germany now at 6th.
Well, bringing it here to Nigeria, the total number of confirmed cases is now at 1,532, with 255 of those discharged and, unfortunately, 44 of those dead. The Nigeria Center for Disease Control, NCDC, has reported 4 new deaths and 195 fresh cases of COVID-19, bringing the total number of infections in the country once again to 1,532.
Well, announcing this early Wednesday, the Nigerian Center for Disease Control says Lagos recorded 18 new cases, Kano 38, Ogun and Bauchi 15 each, Borno 11, Gombe 10, Sokoto 9, Edo and Jigawa 5 each, while Zamfara 2, Rivers State, Enugu, Delta, Nasarawa, and the Federal Capital Territory had 1 each. The NCDC says so far 255 persons had been discharged, while 44 had, unfortunately, lost their lives to the virus. Very sad one there. With us this morning is Professor Akin Abayomi, the Lagos State Commissioner for Health, and one of those leading the fight against the dreaded coronavirus, that's COVID-19, especially in Lagos, where he does a tremendous work at curtailing the spread of the virus. He'll be giving us an update on the COVID-19 situation in the state and other matters arising. It's a pleasure having you, sir, this morning. Great to talk to you. I just would like, if you can hear me, to keep us up to speed with what is happening. The president made a statement on Monday citing new measures like gradually opening up the economy of Lagos, Ogun State, and the FCT with a curfew. I know there was an executive council meeting yesterday in Lagos State. Just keep us up to speed of what is happening now in Lagos as regards COVID-19.
Well, good morning, everybody, and good morning to your listeners. Well, we've got the public health crisis, which is mainly within my domain. And then there's the economic aspect of things, which depends on what happens in the public space and what happens in the economic space. So we're trying to find a balance between having a maximal impact on the public health crisis without necessarily creating an economic collapse or crisis. It's important that we find that happy medium where we are being effective, mainly in the public health space, but also driving and ensuring that the economy of Lagos ticks along without that strategy causing a negative effect on the public health strategies. So that's essentially where we are. As you know, our numbers are gradually rising as expected, but our slope is very gentle compared to other countries around the world. And that may reflect a number of things that we may talk about as this interview progresses.
Well, the rising numbers, we did see rising numbers before the lockdown, and even now that we're in week 5 of it, we are continuing to see increased numbers. So would you say that the objective of the lockdown has been achieved? Have we been able to flatten the curve? Or how would you respond to people that are saying that this is more of an economic, putting the economy first before the health of Nigerians and Lagosians?
Well, the economy is an integral part of the health of the Nigerians. I mean, if you strip Nigerians of their livelihood, then you create a problem. So you don't want to cause a new problem because you're trying to solve another problem. People who are malnourished are more vulnerable to illnesses and viral infections. So part of the public health response is to also have an economic and livelihood response. Malnutrition or shortage of good nutrition will make the population more vulnerable to an infection, particularly of this kind. And it will also affect your ability to respond as an individual. If your immunity is low, then you're more susceptible to catching the virus in the first place, and also perhaps not being able to clear it, and therefore tip yourself into what we describe as the moderate to severe natural history of this kind of infection. So it's not a one cap fit all. You know, we have to look at several aspects of the situation and find a strategy that has the maximum impact on the public health space, as well as ensuring that the people of Lagos and people of Nigeria, you know, are robust enough to fight off this infection.
I'm talking about the strategy of Lagos. It seems it is to admit every positive case as soon as they are confirmed. But as at 2 weeks ago, when you last briefed the press, you did say that Lagos State has gotten to an average of 46% bed capacity of its isolation centers. You also mentioned that Lagos had currently, as at then, over 100 bed spaces left. But we have seen those numbers come in after your last briefing. So my question then is, what is the current capacity bed space in the isolation centers for Lagos? And do you hope to review that strategy as it is done elsewhere, to only take in critical cases and leave those mild and asymptomatic cases in their homes under supervised quarantine?
Yes, so at the moment we're still under the containment phase, which, as you rightly pointed out, is to admit anybody that's positive. And the whole idea about that is to ensure that we're reducing the opportunity for the virus to spread in community. So that's our current strategy. And as our diagnosis rises, because we're testing more, and as the spread is increasing gently in the community, we're opening up more isolation centers. We're looking at hotels. We're converting hotels to isolation centers. We're building new isolation centers. As we admit, we discharge. So there's always a positive and a negative factor to the bed occupancy. We're about to open up Bagada. There's another huge tent in Yaba. We're looking at 4 other hotels that we're trying to convert to isolation facilities. So we're keeping abreast of the rate of diagnosis in Lagos, but as the outbreak continues to gently rise, we know that we're going to get to a point where we have to review that policy, and we're already looking at those strategies whereby we will confine our isolation facilities to patients that have more moderate to severe disease, and somehow use our public health infrastructure, which is quite a large network, to manage very mild or asymptomatic cases in the community. So that's the long-term strategy. We're working towards it. We may not get there, or we may get there faster. It depends on the slope of the curve, and it depends on the dynamic of the infection. As you know, the dynamic of the infection is very different. Even within Nigeria, every state will have its own pattern. And across the world, you can see that there are varying degrees of impact. You know, UK, United States have had it very bad, you know, compared to Nigeria, where our figures look like a drop in the ocean. So that may be attributed to the large amount of preparation that we put in place before the outbreak, or it may be something else that's happening in our environment. So that's where we are right now.
Okay, a lot of people will say the numbers look like a drop in the ocean because we are not testing enough. Tests are just, even despite the fact that we've put in place measures to ramp up testing, it's just a little over 11,000 tests thus far. In comparison to countries like South Africa, that some people have dubbed the king of tests in Africa, comparison to countries like Ghana, which has done well over 60,000 tests, and sort of the new poster child everybody's screaming about now, Senegal, quite doing well with testing. So what are we doing to ramp up testing as regards that? Is there sort of like an arrangement with private labs in Lagos that we can scale quickly to ensure testing? President Trump also called President Muhammad Buhari yesterday, and they talked about ventilators. I'd also like to talk about ventilators. What do we have on ground? But, to have the ventilator is one thing. To have the ensemble that can manage the ventilator is another thing. What skill, what manpower do we have on ground as regards this, sir?
So you've asked me a number of questions there. Let me try and go back to your first question around testing. Well, we're testing the people that are presenting with symptoms. And those that present with symptoms are a reflection of the amount of infection in the community. So the people that come forward to our sample collection sites where we collect the samples, and then we take those samples to our central testing facility. And right now we're getting somewhere between 15 and 20% positivity amongst the people who are presenting with respiratory symptoms or fevers or things like that. So what we're saying now is that 1 in 5 of people in Lagos with respiratory symptoms, that illness is due to COVID-19. So there are hundreds of other pathogens that cause the same thing. So 1 in 5 of all people with respiratory symptoms right now in Lagos seem to be positive for COVID-19. That's not a reflection of what's going on generally in the community. I don't want you to misrepresent that figure. It's not 1 in 5 of Lagosians. It's 1 in 5 of people who are unwell. So that gives us a very nice data matrix. And when you compare that to Europe and the United States, and if you also use the death rate, then yes, there's something different about Lagos and the rest of Nigeria. Either we are in a state of better preparedness, or there's some environmental factor going on, or there's something in our genetics that is helping us slow the trend. But only time will tell. We're still at the beginning of our outbreak, and we don't want to be prophets of doom, but we also have to look at the data that's in front of us and analyze the data and look at the trending and the modeling and see how we can use that kind of information to predict what's coming in the future. So far, our graph is flattish, but even a graph that's flat has a trend, and the trend is still on the uprise, so we haven't reached our peak. We predict that will happen in a month or two, and with this gentle slope, we are preparing for the numbers of cases based on our data analysis and our modeling. Now, your second question was around ventilators, I believe, or was there one before that?
Yeah, no. So it was just a premise about, President Trump saying he'll give Nigerians some ventilators, and the fact that do we have ventilators on ground? How many do we have? And most importantly, the ensemble that manages the ventilators, the skilled manpower.
Okay, so, this whole issue about how to treat severe to critical cases is such a dynamically changing space. We're looking very carefully at what's happening in countries that have very large numbers. I think they admit that they got it wrong right at the beginning of the outbreak, trying to put everyone on a ventilator. We're now discovering that there are alternative ways to manage patients with breathing difficulties. There are different types of oxygen therapy that are not necessarily ventilation. And we are already beginning to see and adapt some of those strategies in our centers here that is improving the outcome of patients who develop these severe complications of respiratory difficulty. We're also beginning to understand a little bit more about the pathophysiology of the disease. In other words, how does the virus cause disease in the body? And it's not as straightforward as we thought. It's not a straightforward respiratory symptom and consequence. We're beginning to understand that the virus is able to interrupt with various systematic events in the body, particularly the blood, the ability of the blood to form clots or to remain in liquid form, the ability of the kidneys to function, the manner in which oxygen is carried around. So that's what I've always said. It's a good idea to keep our graph flat, to reduce the rate of infection so that we can adapt the global trending research ideas and use those effectively in Nigeria. And research really is the key to addressing a new pathogen. A new pathogen is something you've never seen before. So there is no way we as scientists and doctors and health professionals can understand a new pathogen unless we research it. And it's in the research that we're going to define the strategies and the treatment modalities moving forward. Now, our research base in Nigeria is very weak, but we're building that very fast as we can. We're developing research protocols. We're trying to develop our clinical trials. We're looking at laboratory parameters. We're beginning to build a nice research base around our cases in Lagos so that we can understand how it's working in this environment. Once again, you can't just take research from China or America and transpose it immediately to Nigeria. It's a different environment, different people, different genetics. So we have to study how the virus is affecting our people in Lagos and our people in Nigeria and find our solutions. And the incident commander, Governor Babajide Sanwo-Olu, is very well aware of this situation. He's driving the research agenda as well, as are our colleagues in the Nigerian Center for Disease Control and Federal Ministry of Health. You know, while a lot of our energy is being spent on responding, we're beginning to divert a significant amount of resources and energy into trying to understand how this virus functions in our environment and find our solutions in context with what's going on around the world.
Let's speak to ensuring, ensuring compliant physical distancing. I mean, that was dubbed social distancing before. As we approach this May 4th partial ease of this lockdown, we do know that since the ban of rickshaws and, motorcycles, there's been a high concentration of Lagosians at bus stops. So my question to you is there any conversation being done between the Commission between you, the Commissioner for Health, and the NURTW to find out what can be done to make sure that we don't see a case of community transmission just by people trying to get to their places of work once we see an ease in this lockdown?
Well, you must remember that there's a cabinet in Lagos, and the cabinet has its respective commissioners and special advisors, and they're all involved in their respective ways in responding to this outbreak. So the Commissioner of Transport, the Commissioner of Environment are all working in alignment with the Ministry of Health under the Incident Commander to see how we can support each other in the various aspects of transmission and response, feeding. Our job in the Ministry of Health is case management and public health management and medical countermeasures. And I'm supported fully by my colleagues in the Cabinet, and we meet regularly. We have Cabinet meetings. And each and every aspect of life in Lagos is addressed by separate ministries, but we're all synchronized and harmonized to have the overall strategy for Lagos State. So yes, we are all in contact all the time, exchanging information. We're reviewing the data on a regular basis, and that forms the overall Lagos strategy, while each of the respective ministries have their own independent strategies to cope with this outbreak.
Well, Mr. Commissioner, you did mention data earlier, and we really do appreciate that Lagos is data-driven at a time like this. Currently, with the additional 80 cases announced yesterday by the NCDC, Lagos now has 860 active cases. I was wondering, can you avail us of the demographics as regards age and perhaps local government areas and council development areas, because you have reiterated several times your fears and concerns over community transmission, as the imported transmission has reduced since we closed the international borders and airspace. So if you can avail us of those information, if you do have them now.
Well, yes. So at my regular press briefings, I publish those updated data. Yes, our numbers have gone up as expected, but they're not all active. Remember, that's the total number. So several have been discharged. We've discharged over 100 patients. And as of today, we're looking to discharge almost 20 patients altogether. So the number of active cases is still around under 700 when you remove the discharge cases who have cleared the virus. We're still looking at certain hotspots. We're looking at Ikeja, mainland, and Etiosa as the leading hotspots in Lagos. But we've also got our eyes on places like Alimosho, Koshofe, and Badagry. And while we've got our eye across the landscape, we're using data to drive manpower to certain areas to improve our surveillance, particularly in the more densely populated parts of Lagos, where we want to have things in place so that we can heighten and maximize our surveillance through the local governments, through the primary healthcare structures. You know, the response to the outbreak is driven at the grassroots level. So the hierarchy of operation transcends all the way down from the Ministry of Health through the secondary healthcare level to the primary healthcare level at the local government and ward level, where we have our rapid response teams and where all the surveillance and sample taking, as you know now, we've cascaded our sample collection all the way down to grassroots levels, so people don't have to travel long distances to have their tests taken. So we're getting a good sense of what's happening at the grassroots level, at the local government level. Through our door-to-door house search that we've just completed, we got a sense of where there's community activity. And as a result of that information, we've doubled up our surveillance in those areas to ensure that particularly the very vulnerable parts of Lagos are covered with active surveillance.
All right. I wanted us to talk a little bit about mortality ratio. Mortality ratio to case ratio in Lagos State. What is it like? And you talked a lot about your mathematical modeling. Is the mortality ratio to case ratio in tandem with, you know, the sequencing in your mathematical modeling currently? Or are we going overboard? And quickly, I also want to talk about, you know, some of the things, the innovative practices that clinicians are using all over Lagos to help reduce the mortality ratio. You talked about some new innovation in oxygen therapy. If you could expatiate a little bit on that, we'll so much appreciate it, sir.
So, so you've just given us the active cases in Lagos. They've just gone above 800. So far, our death rates are between 20 and 30 that we know of. We're doing a death review on each case, trying to find out exactly what the circumstances around each death are, so that we can pick up a pattern of what are the common features, or you know what's underlying characteristics in people that go into severe to critical state of infection. So far, you know, the common denominator is usually advancing age. It's underlying metabolic syndrome. And what does that mean? That's anybody with diabetes or hypertension. Those two disorders are described as the metabolic syndrome. And then anybody who has underlying condition that affects their immune system. Obesity, we find, is also a possible risk factor. So when we see patients who come in with those types of phenotypes, in other words, metabolic syndrome, advancing age, underlying immunological problems, then we immediately triage them as high risk, even though they may not have presented with high-risk features. And we pay particular attention to those. Those are the type of people that we really want to watch very carefully. And moving forward, you know, we're looking at ways in which we can inform the public that if you fit into any of these categories, you need to be particularly careful. For example, if there's a person with the infection in a home, before you are evacuated, you know, you want to keep granny and grandpa as far away as possible and practice those kinds of social distancing and personal hygiene as much as possible. So these are the kinds of public health interventions we're looking to moving into the future. Now, when you look at our death rate statistics, it's very low. And there might be a number of features that are responsible for that. I've mentioned before that Lagos has a particularly young population. Our demographic profile is young. There might be some environmental factors. You know, we live on the equator. In the equator, we are exposed to quite a number of other corona-like viruses, not COVID-19, but corona family has got thousands and thousands of strains. So it's quite possible that, you know, we've been exposed to different strains of coronavirus in this environment. There are lots of bats around, you know, we all live close to the ecosystem, you know, so it's possible that there is some degree of cross-immunity operating in this environment together with the young age group. Our diet may have something to do with it. Most people in Nigeria eat a traditional diet, which is a lean diet. And so obesity is not necessarily a predominant feature that we see in this environment. When you look at places like the United States, then you see that, you know, obesity and metabolic profiles are becoming a problem there. And that may be accounting for some of the excessive mortalities that we're seeing in those climes.
Let's speak to those asymptomatic patients. About 60 to 70% of people that would be infected with COVID-19 show little to mild symptoms, even though they are still secreting the virus. Now, what does that mean for, you know, our testing rate in Lagos? Are we eventually going to make sure every Lagosian or eventually every Nigerian is tested for COVID-19 just to make sure that we're not seeing the second or third wave of this virus? Well, can begin to answer that question, sir, but we have a few minutes to the break. Can you hear me, sir?
Yes, I can. Do you want me to go ahead now?
Yes, please.
Okay. So, well, you know, there are many ways to make a diagnosis. A test is just a confirmation. So there is a particular case definition. You know, and if you fit a case definition for COVID-19, then it's COVID-19 until proven otherwise. Now, particularly if you're in a cluster or a household where there are 2 or 3 people that are sick with the same symptoms, in this prevailing environment of COVID-19, you know, it's COVID-19 until proven otherwise. Now, you know, we can perform a test, but in medicine, we also operate on what's called case definition diagnosis. So there are typical features of conditions, and if you meet those features, then quite often you don't need a test to confirm it. You just know that this particular patient has the perfect case definition for COVID-19. It fits in the environment of the prevailing circumstances, and therefore you can be managed as COVID-19 until we are able to test you, particularly if you're developing the more moderate to severe symptoms. So testing is not it's not the end all of this game. You know, there's a lot more to medicine.
I hate to interrupt you, sir, but we need to go on that break I told you about. Please stay with us and join us again. Welcome back to the morning show here on Arise News. We're still joined in our Lagos studios by Professor Akin Abayomi, the Lagos State Commissioner for Health, and one of those leading the fight against the dreaded coronavirus. Now, before the break, I was asking you about asymptomatic patients, people who showed little to mild symptoms. So in a case like this, are we going to eventually have to, you know, test everyone to make sure that we're not seeing a second or third wave of COVID-19?
Well, you've hit the nail on the head there. You know, most patients have a mild, almost some people have asymptomatic, some people have mild. That's the order of the day. So, you know, I think it's not fair to call it the dreaded disease because most people are actually don't even know they have it. And those that do know they have it, it's mild to moderate. You have a flu-like illness, you have aches and pains for a few days, you might have a little bit of a cough, might feel tired. And after 2 or 3 days of rest, which, by the way, is the best treatment for COVID-19, especially for the mild to moderate. Rest boosts your immunity. So if you rest well, you get sleep, you rehydrate, you know, you're going to recover without major intervention. So it's only those that really have the risk factors that I've outlined that may become moderate to severe or even critical. And those are the people that we really need to pay attention to. Yes, and as I said earlier on, you know, as doctors, we're getting more and more familiar with this condition. Many of my doctors in the field, they can simply look at a case, look at a patient, look at the environment, and they're almost 100% certain that this is COVID, you know, because you get experienced, you know, and the testing is just there to confirm that this is COVID. And that's where we may apply some of these rapid testing kits that are coming on the market. We're going to validate them first to make sure that they're giving us as high an accuracy as possible. We know that there are many on the market that have an accuracy as low as 30%, so that's not going to be very useful in this environment. So we'll look at the top manufacturers, select a few, put them through a validation process. Once we've completed that validation process, we'll make the announcements in collaboration with NAFDAC and NCDC. And then we may deploy those rapid test kits into the field. You know, once we've made a clinical impression that this is COVID, we may be able to apply a rapid test kit there, right there on the spot, get a diagnosis in a few minutes, and then plan the management according to the policy that we've deployed at the time close by in the future. So yes, testing is important, but testing is not everything. We're doctors, we're trained to make diagnoses on clinical features, to look at the environment, to assess different kinds of events around you, and arrive at an impression. And the laboratory or X-rays are just there to confirm our impression as clinicians.
Well, I like the fact that you have brought in doctors to this conversation, and my question is intertwined in a way, because the Minister of Health in Nigeria announced days back that about 40 doctors have been exposed to the virus. We do know that Lagos has the most numbers of confirmed cases. I wonder if we also have most numbers of doctors unduly exposed to this virus in the course of their duty, and what you are doing to ensure that frontline workers, as well as those beyond the isolation centers, have the PPEs required for them to stay safe. And I did say it was intertwined. There's been this hula below about private hospitals intervening in COVID-19 response in Nigeria, especially in Lagos State. And you have come out to say that so far, only one private hospital has been accredited to participate in the response. I wonder if the situation is still that, or do we have more private hospitals that have been accredited?
You like asking me 3 or 4 questions at once.
I do apologize.
Okay, let me go back to your first question about frontline workers. So part of the problem, and I'll divide that into 2. I just told you that there are many asymptomatic or mild cases. So patients will be walking into our general hospitals, our primary healthcare facilities, into private practices, you know, just complaining of something else, not related to COVID at all, but they're COVID positive. So that's a perfect scenario for transmission of the virus, because the index of suspicion is low because they're not presenting with typical features of COVID. But all our doctors are now trained to exercise a high index of suspicion, to practice universal precautions, infection prevention control for all patients. So you have to just imagine that any patient walking into a health facility is possibly infected with COVID-19, and you just exercise the due precaution. Now, when it comes to PPE to manage patients' personal protective equipment, the most important part of personal protective equipment for COVID, because it's droplet-borne, is the face mask. And the proper face mask, what we call the N95 or FFP2 or FFP3, which forms a seal around the nose and the mouth, because you're going to breathe in the droplets. That's how you get infected. Or if you use a contaminated hand to touch your face, that's how you're going to get COVID. You won't get COVID just by, you know, being around someone who's infected with COVID. You have to breathe it in. So we're protecting our staff with proper breathing apparatus, protective masks, which is why we delayed our Mask Up Lagos. So so that we could get enough masks, handmade masks, made for the community, so that the general public are not consuming the masks that are desirable for our medical personnel. There's a shortage of public personal protective equipment on the market, both in terms of gowns and masks. But the masks are the most important. The goggles and the face shield, that's what protects our doctors and our health professionals. And so we don't want the general public to be wearing medical personal protective equipment. Please leave that for the medical personnel. There's a shortage, it's hard to get hold of, and we want our frontline doctors to be well equipped. Your second question was around
private hospital participation in response to COVID-19. But I do have a follow-up to that PPE question, because you're right, the Mask Up Lagos campaign has started. The incident commander has also announced that there's the production of face masks ongoing. But how do you ensure the efficacy of this material cloth-made mask in Lagos?
So the idea of the face masks is not to protect you, the wearer, from COVID. It's to protect the person next to you. So we know that COVID is droplet-borne, so if even as I speak, I'm producing droplets. If I cough or sneeze, I'm producing droplets. So if you wear a mask and you cover your nose and your mouth, then you are dramatically reducing the droplets that you produce in the environment. And therefore, you're protecting your neighbor. And if your neighbor is wearing a mask, then he's protecting you. So it's I protect you and you protect me concept. And you don't need a medical mask for that. You just need anything that's made from natural fabric with one or two linings that you can breathe through, but it impedes the amount of droplets that you generate into the atmosphere. So that's the whole idea around Mask Up Lagos. Now, masking of medical personnel is a totally different ballgame. Masking of medical personnel, they're inside facilities where everybody is COVID-19. The air is full of droplets. They're more likely to catch the infection by virtue of the work they're doing. And yes, doctors and health personnel, health professionals are getting infected all over the world. It's the nature of the beast. That's our job. We are the front line. We are exposed. And some of us are unfortunately going to get infected. And we're particularly careful about that. We're training our staff as often as we can. We're ensuring that they all have the appropriate personal gear to limit the number of health professionals that are infected by this virus.
And so the private hospital participation?
Yes. So we've engaged with private sector. We've given private sector the opportunity to engage and to participate. Managing COVID is a biosecurity compliant strategy. You can't just open your doors to patients with COVID. You need to go through an accreditation process. We've defined what that process is. HEFAMA, which is our accreditation agency for the Ministry of Health, is engaged with the private sector. Private sector that wants to participate in managing COVID patients are welcome. They make their application to the agency. We go there with infrastructure, biosecurity, and infection prevention control experts. And we define how your private facility can engage if you wish to. Now, many facilities don't want to. And in that case, we still have to engage with you because we have to tell you that many people are going to come into your facility who you don't suspect have COVID, and they will contaminate your facility unless you're able to do a very good triage system. In other words, before people walk into your facility, there's an area where you screen them with questions, you measure their temperature, you ensure that the patients you're seeing, you're reducing the risk of people walking into your facility with COVID and inadvertently affecting or infecting your environment. So the private sector is welcome. We've accredited so far one private sector that delivers some high care for us. Others are going through the process right now. Today, after I leave here, I'm going to inspect 2 or 3 private facilities to see how we can help them adapt their environment to COVID-19. We also train their personnel. We give them instructions and guidelines So it's not all on the shoulders of government. Many private sector facilities are going to participate. As the outbreak expands, we imagine that we're going to need more bed capacity, and if the private sector can come in and support the government in this regard, that is our policy, and we're working. But as you know, this is a public health crisis. Okay. It has to be supervised by the government, and it has to be regulated to make sure that the private sector, for their own sake, are operating under safety guidelines and ensuring the safety of their personnel and other patients within that facility.
Right, amidst all of the tense situation about COVID, some good news coming out of the UK this morning. Boris Johnson, a COVID survivor himself, his fiancée, Kerry Simmons, just had a baby. So I think that's some cheery news in and around the world. But quickly, I hate to do this. I hate to ask you two questions, but I'll ask you two questions, all right? So the first one will be about serum. Correct me if I'm wrong, Lagos State government first talked about serum, collecting serum from the index case, the Italian. Now, other governors, a governor particularly in a certain state is talking about that too. How can we, scale that level of treatment, if there's anything as regards that? I also want to talk about the death protocol, the burial protocol. And I'm saying that because the governor recently gave a 2 weeks timeline and said that most people should go take their bodies from the mortuary and bury them in a season like this. So just talk to me about those two things, sir.
Okay, so the convalescent plasma, or what you described as serum, is the white part of your blood. So your blood is made up of red and white. The white is the liquid that carries the antibodies or the proteins that your body produces when it fights against infection. So if you've just recovered from COVID-19, your white blood will be full of these antibodies that your body has used to eliminate the virus. So that is an opportunity for us to collect that plasma. We have the technology. We've been using it in Lagos for quite a while. We developed it during the Ebola outbreak, and we maintain the infrastructure. We have a biobank, so anybody that's recovered from COVID-19, we request that they donate a unit of white blood. We package that, we store it, we test it, we group it according to blood groups, and we put it in our biobank. And we've been deploying it in certain cases where we have critical patients who we're trying to rescue from going into respiratory failure. So what we do is we're transferring the antibodies that one individual has used to overcome the virus. We're transferring that to another patient who is struggling. And those antibodies recognize the virus in that patient who is struggling. They attack the virus, and they help that individual to overcome their critical state. It's a kind of immunization, but we call it passive immunization. Passive being that the patient we give it to didn't make it. It was donated to them, but it's still immunity, and it's immunity from someone else. We know it's the same virus, so the antibodies will recognize the virus like a lock and key. They will dock into the virus, and they will cause the virus to disintegrate. So that process, we believe, is also going to be put through a clinical trial in Lagos. We're developing the parameters around which to develop a clinical trial to definitely define whether convalescent plasma works or doesn't work. So far, we're using it in what we call compassionate use, so on demand. So in theory, it works around the world. It has been shown to have some benefit. So until we have very hard evidence for its use in Lagos, we're using it on an ad hoc basis where there is a demand, where we feel that somebody may be rescued from severe to critical disease. Then we give them 1 or 2 units of this white plasma from a donor who has recovered from COVID-19. Your next question was...
The funeral protocol,
yes.
Real quickly, sir.
So when you die from COVID, your body is still potentially contagious. So what our morticians do is they decontaminate the body with a solution containing chlorine. They make sure that it's no longer infectious, and then they put the corpse into a body bag, and they transfer the corpse to the mortuary. There's no reason why the family cannot pick up the body. The body is not dangerous after that point in time. We just don't advise that there's touching or washing of the body. As long as the body is put in a casket, even You may zip open the bag under supervision, and we can provide that supervision, but there's no reason why you can't come and collect your deceased and conduct a burial. The reason why there was a backlog in burial is nothing to do with us not releasing COVID deaths. It was to do with the lockdown. But since then, Mr. Governor has said, all burials can carry on. People are dying from other things. It's not just COVID. And we're saying all burials should go ahead, whether they're COVID-related or not. The lockdown is not going to in any way stop a burial ceremony. All we're saying is that don't flout the law of more than 20 to 25 people per congregation around the burial site, and ensure you're practicing safe social distancing.
So as we approach the rainy season, we do know that we're going to start to see increased number of flu cases. Now, because the flu has a lot of characteristics similar with the COVID-19, how does that fare during a pandemic? And also, we do know that obviously there's no cure for COVID-19. However, the immune system of an infected person is very important in battling this disease. What about natural remedies? Talk to me about your traditional medicine research committee. What's being done between these associations and yours?
So, yes, this rainy season is coming. We're going to see a few more flu-like illnesses, colds, coughs, and upper respiratory tracts because of the cold weather. Yes, it might interfere with the profile of the outbreak, so maybe we'll see a drop in the number of COVID-19 related upper respiratory tract infections. So when that comes, we'll deal with it. We'll be able to test and define what is COVID and not COVID. The flu behaves slightly differently to Corona-19. The clinical features are a bit different, so we'll be able to, on a clinical basis, case definition, we might be able to distinguish between one and the other. In terms of immunity, as I said before, your immune system at the moment is the only cure. We haven't defined a drug regimen that's curative. We're working on clinical trials, and we're looking at other events happening around the world. But there is no drug at the moment that specifically targets the virus and eliminates it. So your immune system is your cure. So whatever you can do to boost your immune system, you must do it. Take your vitamins, drink lots of water, eat healthy, rest. While your body is resting, your immune system is at its peak. While you're sleeping, your immune system is fighting for you. If you're busy jogging around the place and being busy doing this, that, and the other, then you're diverting your energy away from your immune system, and your immune system is not as effective. Okay. So as you know, you're not supposed to exercise when you've got an upper respiratory.
Mr. Commissioner, you certainly do not have an easy job navigating the state, the epicenter in Nigeria during these times, perilous times of COVID-19. I do hear we are holding you up for your next meeting, but I wonder how you are holding up and what are the issues that keep you up at night, very quickly before we let you go.
And before I leave, I just want to remind Lagosians that we have our call center. It's 08000 Corona. Please use that number. There is an NCDC number. We're not saying don't call it, but that's in Abuja. The 08000 Corona is the Lagos number. It's a very efficient call center. If you call, you will get through and you'll be attended to immediately. So if you use that number, that's one of the reasons that keeps me up at night. People are saying they can't get through to numbers. They're calling me, and I have to call the call center, and those patients haven't called the call center because they're calling other numbers. So if you call the call center, 08000 Corona, then maybe I might get a few hours of sleep at night.
All right. Thank you so much for that. Really, thank you so much for your time. And please do well to rest and get some sleep.
We do appreciate all the work you're doing in a state like this.
All right. Thank you so much.